of you that don't know me, my name is Cormac Maher. I'm from the University of Michigan. And I presented to the Chiari group last year in Chicago on our database analysis that we've been doing over the past several years in our database of about 65,000 people that are getting an MRI at our institution for any reason. And we've done a number of analyses with this project, most of which we published on already in terms of the natural history studies and the prevalence studies of Chiari. The topic that I've chosen to speak to you about today is Chiari and Scoliosis. And all of this is new. We haven't presented on this topic yet. In fact, I was working on some of the final statistical analysis last night, so it's really hot off the press. I have no conflict of interest. We did get some grant funding from the AANS. So the question, I think, is a familiar one for all of you. Boiled down to its essentials, the question is, so Chiari and scoliosis, what's the relationship there? And we all know that there's some relationship, and seen simply, we think that in most cases, or at least in many cases, I think all of you would agree, it goes through this syrinx intermediary. That is to say, we all agree Chiari can cause a syrinx, and we all agree that in the right setting, syrinx can cause scoliosis. Now, some have suggested, and we'll get into the literature that purports to support this theory, some have suggested that it doesn't stop there, that Chiari can cause scoliosis even in the absence of a syrinx. So that's really the question we're going to examine today. So what's the literature basis of this? There's many papers. I'm just showing you a couple of them here that published all the time. This is just in the last couple of years papers have come out, but there's probably, safe to say, 20 or 30 papers that have come out showing a relationship with Chiari and scoliosis. Here's one of the recent ones. This is the Hopkins group. And they essentially they did posterior faucet decompressions on a group of people that had Chiari and scoliosis. Now these people had syrinx, so it doesn't really address the question that we're eventually going to get to today, which is the syrinx the thing that matters. But if you look at the results here, there's surgical results, which is relatively typical of what's out there in the literature. You can see that after posterior faucet decompression, if you ask the question, who's getting better with scoliosis, who's getting worse, or staying the same, it's a real mixed bag. About half the people are getting worse, and about half the people are getting better or not changing. So a really mixed bag in terms of surgical results, even in those patients with syrinx. And again, caution you one more time, this is not the same as what we're going to be talking about later. This is not patients who have Chiari without syrinx. That's a very typical paper with typical results. Again, you can see the graphs.
Can you put it closer? This time I can't hear you.
Okay, is this better?
Yeah.
Everyone hear me now? Sorry about that.
No.
Looking at the results here, again, this is that Attenello paper from Hopkins, and you can see the simple graphs on the left. Time to improve scoliosis, time to worsen scoliosis, they're fairly equivalent. In other words, surgical results are fairly mixed. It has a lot to do, as you can see in the graph on the right, with whether the syrinx is improving or not. Having said that, almost all their syringes did improve. So this graph on the right is heavily down-weighted. As you can see, the scale is not the same. Here's a similar paper by Krieger and others from Southern California. Essentially, they were asking the same question. People with Chiari and the syrinx, who's getting better if you do a posterior faucet decompression in terms of their scoliosis? And they found essentially the same thing. Some are getting better, some are getting worse. And what they found, and it's been found by Cormac Maher's group and lots of other groups, is that in general, people with scoliosis isn't that bad, less than 20 degrees, tend to not progress. People who have greater than 20 degrees tend to progress. So this information's out there. A fairly strong connection in the literature, Chiari to syrinx to scoliosis. Here's a survey published. I think Brandon is going to be here today, and Benny for sure is here. This is their paper from 2011, and it's based on a survey that was conducted at the American Society of Pediatric Neurosurgery in 2006. They asked all of the people in attendance at that meeting, which in general is senior pediatric neurosurgeons, would you operate on somebody with tonsils of 1 centimeter below the foramen magnum, what was called a large syrinx and scoliosis, and 83% of these senior pediatric neurosurgeons said they would. So again, this is not very controversial. Again, Chiari to syrinx to scoliosis. But here's the controversy. What if you don't have a syrinx? What if somebody has a Chiari and is otherwise asymptomatic? No headaches, no nothing, but they have some scoliosis. Is this an indication for surgery? Is there any relationship that we can build there where we can say we have a chance of making somebody better? And that, in my opinion, is not known. The literature support for this is extremely weak. A number of people have purported to say that there is a relationship, and they speculated that that relationship is because of dorsal column pressure from the cerebellar tonsils on the dorsal columns going unevenly on the two dorsal columns. Most of that speculation comes from case reports or small case series, not a great deal of scientific evidence. Recently, these papers I'm showing you here are from the orthopedic literature. And they've really opened up the door for us to study this again, because these papers are essentially all the same. They're getting MRI scans on everybody with scoliosis that's getting a scoliosis operation. They're asking the question, how many Chiaris are out there? Okay. And they're finding Chiaris, not surprisingly, because we know Chiari is much more common than what people used to believe. So here's one representative paper from Spine in 2011. They studied 923 patients, and they found 91 patients with so-called MRI abnormalities, 12 of which had Chiari malformation. I would suggest to you that actually that's a relatively small number of Chiari malformations, even in the general public. Here's a very controversial paper, also from the journal Spine. They looked at 170 patients, some of whom had scoliosis, some of whom they selected as normal, and here's their results. They measured the cerebellar tonsil position with reference to the foramen magnum, and you can see they have essentially two normal curves here. The position of the tonsil with respect to the foramen magnum in those with scoliosis is on the right, and the normals is on the left. The curve on the left is, again, a relatively small subset of patients, and it's the strangest looking normal distribution I've ever seen. You can see a normal distribution here on the right, and on the left it's like they just cut it off. They didn't find anybody, that's true, but that's not a distribution we tend to see in nature. They concluded that cerebellar tonsils in healthy adolescents are above the foramen magnum, and in scoliosis they're much more likely to be below the foramen magnum. They had an additional conclusion that we should take seriously anybody with 2 millimeters tonsil position below the foramen magnum. But that was very controversial. There was a group of well-respected neurosurgeons that wrote a fairly pointed editorial to that journal, pointing out that they were opening up Pandora's box, and it was a very problematic position to take without any real evidence for it. So it got me thinking about this question a little bit. Essentially, how can they say this graph on the right, this one in scoliosis is abnormal, when they've defined normal with so few people? So we looked at tonsil position in our group of 65,000 patients that are undergoing MRI, and we selected of that group 2,400 patients that we directly reviewed and measured in every age decade. And essentially, here's what we're finding for average tonsil position. The bottom line with this, I presented this at last year's WNS and also at the Chiari meeting, so many of you have seen this before. But the bottom line is tonsil position changes a lot normally with age. So if you're going to define normal position, it depends a lot who you're studying. If you're looking at the young adult age range, tonsil position is lower than what we thought. Again, here, if you're removing anybody with a Chiari diagnosis, the graph stays approximately the same. When you look at a decade-to-decade basis, again, you've seen this graph before, at least many of you have. This is coming out in the Journal of Neurosurgery next month. But if you look at this tonsillar distribution, it's a normal distribution. It doesn't matter what decade you pick. This is 21 to 30, this is 31 to 40, but essentially a normal distribution. This is what you expect in nature with any morphometric measurement. So how does that fit with the graph by Cheng and others? Well, I would argue that it's essentially the same. In other words, I think their evidence that they have found an additional criterion for Chiari surgery is unfounded, based at least on this. Back to our dilemma then. Well, is there any other justification for Chiari surgery for scoliosis in the absence of a syrinx? So we decided we would study the pediatric group in detail, do a chart review of every single patient, find out who had scoliosis, who had Chiari malformation, who had a syrinx, and then look for any independent associations between the two. So we looked at a consecutive series of 14,000 or so children. Everybody had imaging at our institution over an 11-year interval. We defined Chiari for our purposes as 5 millimeters tonsil position below the foramen magnum. That, I think, in itself is controversial in my opinion, but that's how most people define it, and that's how we chose to define it. We had a fairly strict definition for syrinx, that was 3 millimeters width. Some other articles use 2 millimeters in width, but especially in the scoliosis population where it's so common to see the little reedy syrinx or dilated central canal, we wanted to be a little bit more rigorous. And scoliosis, as is the case in much of the orthopedic literature, we defined as any curve greater than 10 degrees. So we did a chart review of 14,000 children, and this is how it broke down. We had 509 patients that had Chiari malformation in that group. We had 347 patients that had a syrinx by our criterion in that group, and we had 1,749 patients that had scoliosis of at least 10 degrees. We can break it down further then, because we're looking for independent associations. Looking now specifically at the Chiari group, 509 had Chiari, but 117 of those had a syrinx. And this is different than what's out there in the literature, because most of the Chiari series in the literature are patients that are symptomatic and getting surgery. So you get syrinx numbers of 75-80%, which makes sense. We have a much lower rate of syrinx because we're looking at a great deal of asymptomatic people. 114 patients had scoliosis, that's 22%. If you look now at the 347 patients that had a syrinx, 181 of those patients had a scoliosis and 166 did not. Similarly, if you look at the 1,700 patients that had scoliosis, 180 had syrinx and 1,500 did not. So what to make of this? Well, now we can do some statistical analysis. I'm going to show you some raw odds ratios, which is univariate analysis, and then we're going to get to the multivariate analysis, which is the real importance of this, I think. Looking specifically at Chiari and scoliosis, is there an association between Chiari and scoliosis? Well, yes, there is. The odds ratio was 2, meaning those with Chiari were twice as likely to have scoliosis in this group than those who didn't, and that was statistically significant. Again, this is a univariate analysis. It does not take the presence or absence of the syrinx into account. Similarly, when you look at scoliosis versus syrinx, you can see an odds ratio of 8. So having a syrinx is highly associated with having scoliosis, according to this, and again, a very significant p-value. We looked at age and gender as well. Female gender, again, not surprisingly, I'm sure, for this group, female gender was significantly associated with having scoliosis, an odds ratio of 1.7. So much less than having a syrinx, a little less than the Chiari, but it was significantly associated. And now here comes the multivariate analysis. We did a logistic regression. We used scoliosis as the outcome variable, and we used age, gender, Chiari status, that is, did you have 5 millimeters or not, and syrinx status, did you have 3 millimeters or not, as our predictors or covariates in this analysis. And here's the data. We'll take it one at a time. Syrinx, again, even on multivariate analysis, is highly associated with having scoliosis. The odds ratio falls from 8 to 7.6, but still a very solid association. And the odds ratio that you see here on the left, if you go to our 95% confidence interval, which I also think is important, that is to say there's a 95% chance that the truth lies somewhere between the number 6 and the number 9.6 in terms of how associated syrinx is with scoliosis. Gender, also highly associated. I showed you in the univariate analysis, gender had an odds ratio of 1.7. Well, that's still the case in the multivariate analysis. Gender is not affected by the presence of all the other variables in the analysis. And again, the confidence limit, it's not as associated as syrinx, but the confidence limit stays good. It stays predictive. In other words, it stays, I should say, associated. Looking at age, the odds ratio is almost, I would say, insignificant. It's statistically significant just because our database was so robust. But an odds ratio of 1.02 doesn't really matter very much in terms of making predictions of association. And again, that goes along with the 95% confidence interval, which stays in the above 1 range, but almost in a clinically insignificant way. It's 1.01 to 1.03, so it doesn't really matter. But here's the main point. When we look at Chiari now in the multivariate analysis, the odds ratio drops from 2 to 1.07. And very significantly, or very importantly, you look at the 95% confidence interval on that number and it crosses 1. In other words, there's a possibility it's either associated positively or negatively or anything in between, but there is not, I think it's fair to say, with 95% confidence, there is not a strong independent correlation between a Chiari and scoliosis in the absence of syrinx, or when you control for the presence of a syrinx. So this is new information that required going through all the scoliosis patients. The beta for presence of syrinx was 1.87 and the beta for gender was 3.42. So back to our question, is there association? Well, again, not based on the very poor existing literature, in my opinion, and not based on this analysis either. We looked briefly at the natural history or outcomes for the group of patients that were in our database that got operated. So you have to treat them differently. Natural history patients, of course, you hope are not operated on. By definition, they can't be in the natural history. And outcomes, of course, are people who are operated on. We had 114 patients that met criteria. They had both scoliosis and Chiari malformation. We had decent follow-up of 5.3 years clinical follow-up. Scoliosis x-ray follow-up was almost 5 years. MRI follow-up was less than that, only 3.5 years. But everybody had these studies. The average age in the Chiari group was 10.5. The average age in the scoliosis group was 9.5. So not very different. As you would expect in a study of this type, most patients were female and most patients had a syrinx. Importantly, when you ask yourself the question, why are these studies getting done in the first place? Well, scoliosis is the most important reason. These patients are presenting with scoliosis, so that's why they're being studied. So that's something to keep in mind when you look at any kind of natural history or outcome graph. You got to say, is this representative of everybody I can see, or is this representative of a certain population? And this is representative to a large extent of people who are getting scoliosis-associated MRIs. There are 21 thoracic curves. There are some papers in the literature that suggest that that's associated with neurogenic scoliosis. It was not associated with syrinx in our series. When we look at the patients in the natural history analysis, those who had a syrinx, those who didn't have a syrinx, just in terms of how they presented, it was relatively similar in terms of the degree of their curve. However, if you look at those who had a small curve that is less than 20 degrees, fewer of those patients had a syrinx than those with a greater than 20-degree curve. So syrinx was associated with a greater number of people with larger curves, if that makes sense. Tonsil position was also, on average, lower in patients that had a syrinx. That's the last line, and that was all statistically significant. So in the natural history study, 55 patients now met natural history criteria. That is to say, there was an initial decision to not perform any operation on these patients. They all had 5 millimeters of descent. They all had a 10-degree curve. They all had 1 year of follow-up. In terms of our natural history results, you can see here, I think it's pretty straightforward. Most people stayed the same. 83% over the clinical follow-up that we had, which was a pretty long time. 13% progressed and 4% regressed. So 2 out of 54 doing nothing just got better, and 13% got worse. So when we're looking at case reports, just as an editorial aside, if you're looking at a case report of somebody who has a Chiari and no syrinx, and you do a posterior fossa decompression and the scoliosis gets a little bit better, I would suggest to you that that's not a strong enough level of evidence to say that there's a relationship there, especially when we can see that in a natural history analysis this happens occasionally from time to time. Again, looking now specifically at what's different about those who progressed or were stable or who regressed, surprisingly, tonsil position didn't have much to do with it. You can see that the group that was stable had a little bit more tonsillar, I don't want to use the word tonsillar descent, lower tonsillar position compared to those who progressed. The degree of initial curve was also relatively similar. This, though, I think bears mentioning, although the number who regressed was tiny, they didn't have a syrinx, and the ones who did were either stable or progressed. So 55 patients, as I've told you, 23 never underwent surgery at any point in our institution, and you can see the follow-ups there. 26 underwent posterior fossa decompression at some point. Many of these patients never got worse. They just were in our system for long enough, and people kept seeing them, and they had the same presentation as always, and for some reason that's not very clear in a retrospective analysis. They eventually got surgery. And 5 underwent spinal fusion. If you look at change in curve in those who did not undergo surgery, the change in curve was 0 degrees, so they never changed, at least on average. There were quite a few that changed a lot, but on average they didn't change. The people who underwent posterior fossa decompression all had a really minimal change, on average 4 degrees in curve change, so not much. That didn't seem to be the deciding factor in surgery in any of these cases, or many of these cases. And 5 underwent fusion, and not surprisingly, this group changed a lot with respect to their curve. If you look at the surgery outcome analysis, now these are data that are somewhat analogous to, say, the Brockmeyer paper or the USC paper that have been presented, saying if you do a posterior facet decompression on people who have a syrinx and scoliosis, what's going to happen. We had 87 patients in our series, and most were female. Most had a syrinx. 28% had a left thoracic curve. The initial curve was 33 degrees, so quite a bit. The initial tonsillar descent was almost 13 millimeters. We usually do duroplasties in our institution. I don't think there's any real good data one way or the other on whether that's necessary, but it always seems to come up for discussion. I will say, again, as an editorial, we're starting to do it a little bit less than we used to. Syrinx progression, 89% of the time post-operatively. Curve progression was pretty minimal. When you average the entire group, you have a 0.3 degrees curve to change, which is essentially nothing. 29% of the group, though, almost 30% of the group, had to undergo some second surgery. In 22 cases, it was a spinal instrumentation procedure. So after the Chiari decompression, they had a spinal instrumentation. And in 3 cases, we redid the posterior facet decompression. If you look at associations between those who needed some second surgery, the scoliosis surgery, the Chiari surgery, or those who didn't, you can see the curve progression was highly associated. Not surprisingly, those who are having curve progression are on a radar screen and getting a second surgery. And those who had a very severe initial curve, 50 degrees on average, needed a second operation, whereas those who didn't were only 27 degrees. Syrinx and change in syrinx width were not significantly associated, so syrinx by itself was not predictive in this particular group. So I'll conclude and take any questions. I'll just say that Chiari is associated with syrinx, and syrinx is associated with scoliosis. That's not controversial. But there is no independent association between low tonsil position and scoliosis. We examined association, not causation, but a lack of association does imply a lack of causation. And you can infer then, in the absence of any causation, that there's also a lack of any therapeutic effect. Greater initial curve predicts a need for scoliosis surgery after the posterior facet decompression. And this is really from our larger series, the 65,000 series, but cerebellar tonsil position, I will suggest, like most morphometric measurements in the body, follows a normal distribution that's different at different ages, but is always normal. 5 millimeter descent should not be, in my opinion, considered a pathological cut point, but instead should be considered the low end of a morphometric normal distribution that is associated with symptoms in some individuals. Thanks very much.
Cormac,
Yes.
I have to say this is fantastic. Every 3 or 4 years, I see a paper that changes the way I do things, and this will definitely change the way I do
No,
things.
thanks very much.
And I will just tell the group not to embarrass Cormac, but this is really representative of the work that he's been doing. He's really defined the prevalence and natural history of multiple congenital anomalies, including arachnosis and the Chiari malformation, which is important to us. It's very easy when you have access to large databases that you do the wrong thing and you do it in a sloppy fashion and you come up with wrong conclusions. They've done it in an impeccable way, and I think it's important. One question I have for you is, orthopedic surgeons operate on idiopathic scoliosis all the time without scan. What is the percentage, do you know the percentage of idiopathic scoliosis that actually ends up having neuro-MRI findings?
Yeah, well, that depends on the institution that you're studying. In institutions that have made it a practice to study everybody, some of the better papers are from China, actually the Cheng paper, which I showed you, where they studied 921 patients and they found 90-something people with neurological abnormalities. Some of those are not things that would necessarily get our attention, though, in the clinic. Vague problems that we wouldn't operate on anyway. But in 12 cases, they found a Chiari, which, if anything, is surprisingly low. But they also found 1 case of tenoid cord and some other things. In our institution, we're not rigorous about getting an MRI on everybody, so that's why this study wasn't a clinical study looking at everybody with scoliosis. It's a imaging database of everybody in our system that we know to have scoliosis. Yes.
So I just want to make sure I understand it, just because I don't have obviously the background. But so if you have a child that has a scoliosis, there's a high degree of probability they could have a Syring's. Is that, am I?
There is an association for sure.
High
Now,
association?
I didn't get into that today, but Syring's and scoliosis are associated. Now, some of that is because Chiari can cause a Syring's, which can cause a scoliosis, and some of that is because of frankly, a different Syring's pattern, which we're looking at right now, which for the neurosurgeons in the room, I'm sure you've all seen it, where there's a significant curve. You see this little thin, reedy Syring's at the apex of the curve. And so that's part of why you see this significant association. It's a chicken and the egg phenomenon. In some cases, you see a Chiari causing a Syring's, which causes scoliosis. In some cases, you see a severe scoliosis, which is causing a little thin, reedy Syring's. So it can be a epiphenomenon rather than a phenomenon.
So would you want to, as a rule, if you had a scoliosis, would you want to MRI?
No, definitely not.
No. So you wanted to say to yourself, there's got to be a high probability there's a
Yeah,
3D Syring's
That's right.
anyway.
In the absence
Okay.
of neurological findings, I would never recommend screening MRIs. I think we get into trouble that way.
To push Lori's question further, but in that rare patient that does have Syring's as the etiology of the scoliosis, now you've got hardware in, and you really can't assess things very well.
Yeah, that's true. It's a relatively unusual thing for a scoliosis patient with a completely normal neurological exam and to not have any of the risk factors that the orthopedic surgeons talk about, such as very young age or left curve or very rapid progression, that sort of thing, to have a true neurological abnormality in the MRI. The trouble with doing that to screen everybody to find this rare patient you're talking about is that we have a deluge of patients that are completely normal, that are getting inappropriate medical care because somebody got an MRI.
Yes. So do you trust your orthopedic pediatric
Yeah,
surgeons
I
to
do.
do that exam?
I do. They do a very good job. Yeah, it's not part of this talk, but I could show you data if anyone's interested. Do we have a minute? Do we have 30 seconds? I'll get there as quick as I can. On MRI use in this country, where did it go? There it is. And so this is MRI use in America since 1996. You can see how many studies we're getting now compared to how many studies we were getting just 15 years ago. It's really taking off. It varies quite a lot by geographic distribution. If you look at the United States, it's up here, getting 91 per 1,000 population. If you look at the average, it's 41. If you look at Canada, our neighbor to the north, if you live in Canada, you have a 1 in 3. How do I word this properly? If you live in America, you have a 3 times risk of getting an MRI compared to a Canadian citizen. So there is an epidemic of MRI use in this country, and we're finding all sorts of problems as a result of that. Depends a lot on where you live, too. Here are data, again, I showed you America versus the rest of the world. Here's individual cities in America, and depending on if you live in Atlanta up here at the top, or Boston, or Dallas, or Seattle, or San Francisco down here at the bottom, you have a significantly different chance of having an MRI scan when you go to see the doctor. So there are profound geographical differences in who's getting MRI scans around the country and around the world. And there's a cost to that. Obviously, there's a cost of getting the MRI scan, but the real cost is starting the cascade, the clinical cascade of finding something, because you find something frequently on MRIs, and then it's got to be explained. Explaining it is costly, but hopefully it's not too hard on the patient. But then in some cases, it leads to inappropriate treatments, and that's where the real cost is. Yeah.
I had sort of a what would you do kind of question. If you had a child who had a significant degree, maybe more than 20 degrees scoliosis, and their neurologic exam was normal, you wouldn't MRI that child?
No, not if they were typical for scoliosis. If it was an adolescent, if it was a girl.
The only problem I find with that is when from when neurologists look at some of these people, in my own personal experience, that some, certainly, we can all recall numbers of patients who had absolutely gigantic syrinxes whose neurologic exam was absolutely normal. And I think I'd like to know that. And
Well, I think
I don't know why. I mean, how much of a risk is the MRI? I'll never forget. Maybe 20 years ago, in our Department of Neurology, I had brought in a fax machine. You know, one of the neurologists said, you brought in a fax machine. Before you know it, everybody's going to be using it. And yeah, that's true.
it really is.
I understand your point about how do you explain things that you have to be smart enough, I guess, not to operate on things that don't need to be operated on. But just because you find things, is knowledge ever a bad thing? I would ask.
I think it is in general, because I don't think people are smart enough to not operate on things they shouldn't be operating on.
All right.
There is one study, a small study, a little bit of data. There was an executive scanning facility in California. I think you paid $10,000 up front. You could walk off the street and get scanned, having no clinical reason. You paid for it. 24% had an abnormality that required additional testing, and only 2% was it clinically relevant.
Yeah, and that was in the eye of the beholder. That was in the eye of the person who was actually offering the treatment. So, I mean, you could even make the case that it was lower than 2% in reality. But yeah, that's the problem. And yet, there are a number of studies that have looked at that. There's a great study in the New England Journal of Medicine. Vernuige is the lead author, where they just got 2,000 normal people and paid them some money, and they got in the scanner and they found stuff. I'm sure all of you have seen it. It happens all the time.
Algorithm may help, because if I understand, Starbucks in Seattle is contracted with one of the health concerns there. Their cost of scanning Starbucks employees' lower back, because the back was fairly high. In other words, a lot of Starbucks employees that sought medical. The algorithm dropped it down to, I don't know, 1 out of 10 that really needed that scan.
Right. Yeah, and according to at least the insurance data that I just showed you, Seattle was the best big city in the country in terms of not ordering a lot of scans. Maybe that's why.
At least once a week, I see a patient that with a very slit-like syrinx, or whatever you want to call it. And of course, the patient and all the prior physicians that have treated all the patient's problems do that.
Right.
I call it a persistent central canal.
Yeah.
Could you just elaborate on that?
Yeah. Well,
you brought it up.
Yeah, I'm a big believer in what you just said, that there are differences in syrinx quality and size and everything else. And the syrinxes that I worry about, probably like the other surgeons in the room, are the ones associated with some cause that are big. If it's causing either scoliosis or symptom, okay, then you've met my criteria. But for everybody like that, I see a handful of other people that have scoliosis and have the thin, reedy syrinx. That's just at the apex of the curve. We see it all the time. I think you can call it what you want to call it, a persistence of the central canal, or call it a thin, reedy syrinx, as I've been doing. But I don't think that has any clinical importance, and I never treat them. Unfortunately, I don't have data to share with you today. I don't even actually know the data myself, but I have people working on that question right now, because in our database I've been asking them, what's the difference in people who have a Chiari and syrinx and scoliosis, people who don't have a Chiari and have syrinx and scoliosis? And I think we're going to find a difference. The non-Chiari syringes that have scoliosis are going to be, I think, thinner and at the apex. I think we'll see that, whereas the Chiari-associated syringes that cause scoliosis are going to be cervical, not associated with the apex of the curve, in most cases anyway, and are going to be much wider. So that's what I think, that's my bias, but I don't have data to support that as of now. Hopefully so.